So this is the fourth class that we have for this HPB Congress, online Congress. So I'd like to wish everybody good evening and to introduce myself to the ones that don't know me. I'm Dr. João Nicoluza. I am a digestive surgeon. And the hospital that I work is Angelina Caron in Curitiba from South Brazil. I also would like to make some thanks, especially to the people who are supporting us, and as the 1,500 people who got enrolled for this Congress. So we have 1,500 people enrolled for this Congress. I also would like to thank to the panelists and introduce them for you. So the first panelist that we're going to have tonight is Dr. Agatha Hottert, who is an oncologic surgeon from Curitiba, from São Vicente Hospital. Thank you very much for being here tonight, Agatha.
Thank you. Thank you for the invite. I'm anxious about the session.
And the next panelist, my friend from long time, Dr. Coimbra, Felipe Coimbra, who is head of the digestive section of AC Camargo Hospital, one of the most important hospitals in the whole country, probably Latin America, in the field of oncologic surgery, and who also has a great experience in pancreatic surgery. Thank you for being here.
Thank you, João. It's a pleasure. Very
And
happy.
in our lecture tonight is going to be about pancreatic fistula, certainly the pitfall of pancreatic surgery. And Professor Sébastien Gaujoux from PTA Hospital from Paris is going to present us his experience in how to try to manage and to avoid it. He belongs to one of the most important hospitals in Europe and probably in the world. Thank you for being with us once again for the third time, Professor Gaujoux. Thank you very much.
Thank you so much for your kind work and your great invitation. And I'm always pleased and being so happy to be with my Brazilian friends. So for the following minutes, we are going to discuss on pancreatic fistula. First, I have no conflict of interest, unfortunately. And as you know, pancreatic surgery is a quite tough surgery. Those are nationwide German data. And what can you look at them? You can looking at all Germany, you have a 10% mortality, a 16% reoperation rate, and a 20% rate of patients needing more than 6-pack of transfusion. So clearly, even if you all know a few high volume centers such as Heidelberg, overall nationwide pancreatic surgery is associated with poor result in surgery. Of course, that shouldn't be the same in France. But if you are quite honest with our results, those data are already more than 10, 15 years ago, but it's not so long. Look at French 90-day mortality. It was 9%, 8% overall, more than 9% after Whipple, and 6% after distal. And those are nationwide data from insurance data set with no way to hide your poor results. So clearly, most of those deaths are in relation with surgical complications, the most frequent and the most threatening of them being the pancreatic fistula. Pancreatic fistula remain, in fact, a fatality. When you look at the surgical literature, you can see that every year there is an increasing number of published articles. And if you look carefully at the randomized control studies in pancreatic surgery over the last 20 years, most of them are dealing with the prevention of pancreatic fistula, which is clearly still key in the management of our patients. And clearly, that is a big threat and a big deal for most of for surgeons and patients. So the question is how to manage high-risk pancreatic remnants when you want to clearly avoid those pancreatic fistula. And clearly, how to manage those pancreatic remnants and avoid pancreatic fistula, or if you cannot avoid them, at least reduce their consequences, and of course, reduce postoperative mortality. I think there is 3 main points that you need to do. First, you need to identify who are your high-risk patients. When you know those high-risk patients, you need to prevent pancreatic fistula occurrence if it's not possible to prevent its consequences. And when you have a pancreatic fistula, you need to know how to manage it. And we won't see this last part, which is that will be too long to develop, but I will give you a couple of key to better manage the patients. First, clearly, it's identifying high-risk patients. So there is numerous risk factors that had been identified to clearly define the high-risk patient, and I call them the 5 P. So the first P is in relation with patients. You know that when your patients are obese, when their obesity is 100, as in most male, when this is associated with denutrition, sarcopenia, and other treatments of corticotherapy or anticoagulation, those are at high risk of pancreatic fistula. So the other P is the pancreas. When you have a main pancreatic duct dilatation or no, when you have a fatty pancreas, when you have a soft or hard pancreas, when you have like a poor vascularization of the pancreas, those are also risk factor for pancreatic fistula. So patients, pancreas. After you have pathology, when you have like a pancreatic ductal adenocarcinoma or chronic pancreatitis, this clearly decreases the rate of pancreatic fistula. On the opposite, when you have an ampuloma, a pancreatic neuroendocrine tumor, or when you're operating for cystic lesion on soft pancreas with a small pancreatic duct, clearly those are at high risk of pancreatic fistula. After the procedures also clearly influence the risk of pancreatic fistula. Distal Whipples, when you do Whipples, and clearly we will focus on Whipple during those talks. The type of anastomosis you are doing, pancreaticojejunostomy or pancreaticogastrotomy, will influence, and we will see that later. You need to put a drain? If yes, internal or external drain. The expertise and the volume of your centers, your skillfulness, the blood loss, and the volume of fluid resuscitation will also influence your pancreatic fistula risk. And after, there is the postoperative management. What is the amylase on postoperative D1? Are you using somatostatin, hydrocortisone, or to manage your patient, and are you centralizing surgery? So clearly, those 5 P, patients, pancreas, pathology, procedure, and postoperative care, will influence your risk factor for pancreatic fistula. But most of them are not modifiable before the surgery. So you cannot modify them even if you try. And if you have an obese patient, there is no way to make him or her less fat within a couple of weeks. So clearly that's an important question. So when you're identifying your RX patients, clearly what is very important and very useful nowadays is to use fistula risk curve. And you can clearly calculate them online during your clinics using, for example, these addresses. And those fistula risk curves, the calorie one published 10 years ago is the most used. Those fistula risks are based on gland textures, firm or soft, on the pathology, pancreatic ductal adenocarcinoma and pancreatitis versus the other one, on the pancreatic duct diameter from below 1 to above 5, and the intraoperative blood loss. And when you consider those fistula risk score, you can see that the fistula risk score can go from 1 to 10, and that is clearly associated with the clinically relevant postoperative pancreatic fistula. And when your fistula risk score is 0, clearly you have no fistula. When it's low, between 1 and 2, the fistula risk is around 5%. When it's between 3 and 6, fistula risk score is, let's say, between 10 and 15, 12%. But when your fistula risk score is above 7, you have a risk of clinically relevant postoperative pancreatic fistula around 25%. And clearly, those 20-25% of patients carrying a high risk of pancreatic fistula, you need to identify them before your surgery. There is also other fistula risk score. You have the modified fistula risk scores, the alternative fistula risk scores, and so and so. All of them, clearly, they are quite the same, and they are almost equally useful to predict grade B/C clinically relevant pancreatic fistula, which is about 20% of patients. But what the issue, if you can predict B/C pancreatic fistula, what you want in your daily practice is to define or differentiate grade B to grade C pancreatic fistula. And grade C, that are the pancreatic fistula that are killing your patients. They occur in less than 2% of patients. And nowadays, it is very, excuse me, it's quite late in France. It's nowadays very, very difficult to accurately predict those grade C pancreatic fistula. And in this article, they clearly say that in multivariate analysis, there was no independent risk factor. So clearly, differentiating grade C or B3 pancreatic fistula that need interventional procedure is nowadays almost impossible. So clearly, if we are good enough to predict grade BC pancreatic fistula, we are still not accurate enough to identify higher risk patients for grade C pancreatic fistula. So we know that it's quite easy to predict grade BC pancreatic fistula, but unfortunately grade BC know how to prevent those pancreatic fistula, and possibly more important, how to prevent consequences of postoperative pancreatic fistula. There is several ways to do it. There is a technical prevention. How are you doing your anastomosis? Are you using drain? Are you using your mental flap? Are you totalizing your procedure? There is a pharmacological prevention using neoadjuvant treatment, somatostatin analogs, or hydrocortisone. And there is organizational prevention using centralization and standardization. So first, we should look at pancreatic anastomosis. Look how many of them as being described, a lot of them. So nowadays, which one you should do and which one you should avoid. So clearly, that is key to understand. Which one should be avoided? The one with anastomotic occlusion. When you're using glue to occlude your main pancreatic duct, just avoid it. The dual Roux-en-Y loop also is useless. The Brown enterostomy, using again anastomosis, is useless. And the Panc-binding pancreaticoduodenostomy, when you do an anticipation of the pancreas within the small bowel, also is associated with more hemorrhage. And clearly those 4 techniques should be avoided nowadays. So which one you should use if you're not performing those 4? Clearly, should you do a pancreaticoduodenostomy or a pancreaticogastrostomy? A lot of trials and a lot of prospective ones. When you look at the meta-analysis, possibly possibly pancreatic gastrostomy may be associated with a very slight lower rate of grade BC postoperative pancreatic fistula, but pancreatic gastrostomy is associated with an higher rate of grade BC postoperative hemorrhages. First. Second, when you're doing a pancreatic gastrostomy and you have a fistula, how are you dealing with the nasogastric tube and oral feeding? And if you're doing a pancreatic gastrostomy, which one is the best technique? Clearly difficult to answer. And that is why, because of an higher risk of hemorrhage and a difficulty to do an oral feeding after a fistula, clearly nowadays I'm doing pancreatic jejunostomy in most of patients. So if, as I'm doing, you prefer pancreatic jejunostomy, which one should you do? A duct to mucosa or one with duct to mucosa and invagination? Difficult to say, and clearly meta-analysis show there is maybe a slight tendency in favor of invagination, and maybe there is a possible advantage of the Bloom-Gard tip anastomosis in some randomized controlled trial, but not all. So clearly there is no big winner in that, and so do the anastomosis you're used to do, because that will be in your run the best one. So pancreatic, which kind of anastomosis? Second, should you use stent? And if yes, internal or external? Quite difficult to answer, and the Cochrane library might help us. Clearly, when they are looking at the very few studies, only 3 randomized controlled studies comparing stent and no stent, there is a very slight tendency in favor of the stent stations. But when you're using the stent, should you use internal stent or external stent? Possibly external more than internal. But the conclusion of those Cochrane meta-analyses is that clearly they have not been able to identify convincing direct evidence of the superiority of external over internal stent. So clearly, maybe external dent might be better than nothing, but it's very hard to prove it. And nowadays, the level of evidence, it's too low to clearly advocate that for all high-risk patients. So a recent study, when you have a high-risk patient, should you do a pancreatic jejunostomy and stent or pancreatic gastrostomy and stents? Clearly, that was a single center phase 3 randomized controlled trial. And what they said that maybe for high-risk patients, pancreatic jejunostomy with external stent and no octreotide or somatostatin analog might be the most appropriate technical strategy. So you need to know this article, but clearly still the level of evidence is quite low. So be careful also when you are using drain. You need to know that in about a third of cases, there is a drain malfunctions. And when you have a drain malfunctions, you increase by 2 the risk of postoperative pancreatic fistula. So what about intraperitoneal drain? Should you drain or nose in pancreatic duodenectomy? In pancreatic duodenectomy, there was the result of the Van Buren trials 10 years ago. You should drain because no drainage increased the mortality. But there is also a recent study of a Dutch trial showing that in distal pancreatectomy, drain omission is safe because it's not associated with more morbidity or mortality. So clearly, when you're doing a Whipple, use a drain, especially in high-risk pancreatic patients. When you're doing a distal, those drain might be omitted. But the key question, I think, is not to say, okay, putting a drain or not, is when you put a drain, you might, I'm sorry, you might remove them earlier than later. And nowadays, I think early drain removal is the best approach in those patients. So you're doing your anastomosis, you put a stent or a drain, and you're doing an abandon flap. I think that is useful, but when you're doing an ambassador flap, which one could you do? There is a ton of them, and I think that every surgeon has his own abandon flap. And clearly, I will show you two French techniques. The first one, when you're dividing into your omentum and you wrap it around your anastomosis. The other one, when you make a hole within your omentum and you do the anastomosis after. Those are two French examples. There is many of them. Another way to avoid pancreatic fistula, and that the easiest way when you're considering a Whipple, is you can do a total pancreatectomy. Is it the solution? That might be interesting, and there is quite a few articles to know. Clearly, this one show that might be a solution in very selected patients. The other one also, they are reluctant, but that might help to reduce the mortality in clearly high risk and frail patients. So clearly, total pancreatitis in selected patients might be the solution. And there is ongoing studies, and all today, I will consider that for very selected patients only. I mean the ones that are obese with high-risk pancreatic fistula and which has, in addition, the need for an anticoagulation. So clearly, I would recommend a dedicated MRI or a dedicated CT in those patients. But you cannot, explore all patients for that. So clearly, you also need total pancreatectomy, then be a way to do it. And nowadays, using the freestyle and all the captors, it's much more easier when you're doing with those complex diabetes. There is another important stuff when you're doing anastomosis is your technical skills. And there is this very nice study showing that when you're like grading surgical technical performance, you predict the various risks of postoperative pancreatic fistula. So surgery remain a technical activities, and you need to practice again and practice again. And more you are doing, less pancreatic fistula you have. So clearly, we need you, and we need your technical skills. So last, pharmacological preventions. First, neoadjuvant treatments. We know that when you're doing neoadjuvant treatments, there is a lower risk of pancreatic fistula. You can either do FOLFIRINOX or chemoradiotherapy. And in the PROPANC trial, they show that postoperative pancreatic fistula rate was 0% in those groups. So that might be a very interesting things to do. And there is the FIBROPANC trial showing or trying to show that preoperative radiotherapy might help to decrease the fistula. That's an ongoing trial. We will see. After octreotide, should you use it or no? Clearly, it's very difficult. There have been more than 12 randomized controlled trials with about 2,000 patient studies. And clearly, when you look at those trials, it's quite difficult to know if they are like significant or no. The meta-analysis show there is a small favor for POPF prevention with octreotide, but clearly difficult to say. When it's multicentric, that's helped. When it's in Europe, that's helped. And when it's high-risk patient, that helps. So clearly, I think that that might help. Octreotide or somatostatin analog might help when you're dealing with those patients. So clearly today, what should we do? It's still under debate, but using somatostatin analog for prevention may be interesting. But that was also before this New England Journal of Medicine article from Peter Allen. It's a randomized controlled trial, double-blind, using pasiroted compared to placebo. What they show that there is a 50% significant decrease of fistula and abscess at 15 days, and considering all patients. Are dreams becoming true, or is it too beautiful to come true? Clearly, it's different and difficult to say, because in the real life, those results have not been reproduced, and with a possible low efficiency and maybe harmful when you're using somatostatin, because they say that it was associated in this study to higher risk of fistula, so because it might decrease the splenic blood flow. So nobody always knows, but for me, I think that a somatostatin analog might be used in high-risk pancreatic pancreas. Next, neoadjuvant treatment, somatostatin analog of hydrocortisone. Hydrocortisone, by reducing inflammations, might help, as in this Nordic trial, might help to decrease postoperative fistula. When you compare pasirotic and hydrocortisone, it's not clear, but clearly it seems to have benefits for hydrocortisone, at least in high-risk patients. But nowadays, nobody can say. On my point of view, I'm not using hydrocortisone for that. Sorry. Then, when you're performing a pancreatic surgery, think of your surgical indication. Clearly, in about 10% of cases, you're performing, especially for cystic lesion, so pancreatectomy for non-neoplastic cysts. So clearly, have a careful look at the patient file before operatively, and clearly use as many examinations you need to have an accurate preoperative diagnosis. And also, when you need to assess the benefits-risk balance of a procedure, use this NSQIP calculator that will help you to calculate the surgical risk in your patients. And as for some high-risk patient, as for obese one, it might be safe to delay or defer, especially for non-malignant lesion, the pancreaticoduodenectomy. And lastly, we have now the organizational preventions. What we know is that morbidity is not the cause of death. What is the cause of death is failure to rescue after complication. You can see that the mortality is clearly associated not with the major complication rate, which is quite the same, but is associated with the failure to rescue. So that means when you have an hemorrhage, you need to be good enough to send it to radiological interventions or to surgery again. So clearly, today, postoperative mortality is not a fatality. And you need to know this trial. That is the Porsche trial published by the Dutch group in the Lancet. And clearly, they show that on a nationwide perspective, they can decrease by 50% the 90-day mortality just using easy-to-use algorithm. So clearly, it's important to know those. So I'm going to conclude and give you some take-home message. Clearly, pancreatic fistula might still be a fatality, but clearly morbidity and mortality associated with pancreatic fistula is no more a fatality. And on a clinical perspective, you need to identify risk patients to prevent those pancreatic fistula and manage it. I did not study and maybe develop that, but you need to manage those patients using the Porsche algorithm is, I think, nowadays the best thing to do. So when you need to identify risk patients, think of the 5P and the fistula risk score. When you need to prevent pancreatic fistula, remember that you have technical preventions, pharmacological preventions, and organizational prevention. And when you need to manage pancreatic fistula, look at the Dutch group with the Porsche trials, and I will be more than happy to discuss that will be next year. So clearly, remember also that God put the pancreas in the back because he didn't want surgeon messing with it. Be very careful at your surgical indications, and I'm very happy to be with you tonight. Thank you for your attention.
Thank you very much indeed, Sébastien.
You're welcome. Thank you.
It was amazing, as always, and very direct presentation in exactly what we need to hear as surgeons. I mean, I think that you have chosen all the main aspects and main points, like the choice of surgery, pharmacological prevention, and the post drainage. Well, so I'm gonna open the discussion for Dr. Felipe and Dr. Agatha to enjoy your experience, but after that, I have some personal questions too. So, Felipe, maybe you wanted to start? Just want to ask Sebastian if you could stop your sharing, please.
Yeah.
Yes, thank you, João. Congratulations again. Very nice congress, online congress, very accessible for all, yeah. And this is very important too. And congratulations, Professor Sebastian. Very clear and direct presentation. I think for all that are watching us tonight, it was probably very easy to understand for those who are not so used to pancreas, and for those who are very used. Some nice insights on the main points to avoid, to prevent, and to treat these complications. Probably this is the most important. After a while doing pancreatic resections, and after a learning curve, either by open laparoscopic or robotic, the pancreatic fistula I probably is the main cause of morbidity, death, in hospital stay, and costs, increased costs. So this is something you have to use as a target to improve our results in pancreatic resections for all the causes, all the types of diseases. And so I think, please go ahead.
No,
Yeah.
go ahead.
Yeah. So I think you pointed out the main issues, such as technical, physiological, patient with organizational, and I think you also highlighted a very important point on how to rescue. The rescuing of the pancreatic fistula complications are very important. I think there is some data recently also highlighting this. And of course, depending on the structure you have in your hospital, it would be different. And I can see from, for example, from our own experience, if I see like 2 decades, 1 decade, and 5 years from now, we have changed a lot our management of these patients by having more access to interventional radiologists, team, specialized team, and also on the intensive therapy unit, so they can help a lot us when it's necessary, when the patients really inflammates quite a lot in some very few cases. So I have maybe a few questions. I'd like to know your opinion on some of them. Please be free to comment on anything you wish. So I'd like to know, we have been talking a lot on rehabilitation of these patients as we can, as possible. Of course, we're not talking about those patients with this malnourishment that you have to treat them before, but like physical activity before surgery, nutrition preparation, changing bad habits, of course, maybe tobacco using. You have few data on that, right? And not specifically. So I'd like to know your opinion. Probably I would be glad if you have the data, but if you don't, just give your opinion. That would be very important for us to.
No, it's rehabilitation is very important nowadays, but clearly, in my opinion, even if it's very important, it's quite difficult to show that rehabilitation reduce mortality. And when you like first see a patient with pancreatic ductal adenocarcinoma, there is so many things to do: MRI, CT scan, markers, anesthesiology, prepare them for surgery, like doing all the step of rehabilitation outside the trial or very specific institutions. It's quite expensive, time consuming, and very few of patients have a true rehabilitation. But clearly, if you can do it, you should do it. But it's like very, I mean, it's very costly in terms of, like for the patient and the institution. So clearly, we try to rehabilitate of patients as much as we can using, like total parenteral nutrition, enteral nutrition, and so. But we try to do it even if it's sometimes difficult.
Yeah, no, I see. And also, I will point out like 3 or 4 topics. If you wish, you can comment and give your opinion, of course, about antibiotics during the surgery. There's a paper from Memorial and other groups showing that maybe one of more ample spectrum antibiotics may reduce infection, but also may, and we don't know why, reduce pancreatic fistula. So there is maybe a role for microbiota or other aspects, or maybe infection. So this would be one point. Another point is on minimally-invasive. For example, we don't train routinely anymore for distal pancreatectomy. I don't know what you do, but that's also a risk. And one very important point, for some of these patients, it doesn't matter if it's to the head or to the left side, when patients do pancreatitis. Is it a risk for fistula? What do you think? I always expect fistula when I have pancreatitis. We don't know exactly if it's fistula or if it's transudation of amyloidosis, but does it change for you the management?
Yeah, so the 3 questions. The first one on antibiotics. There is this very nice paper in JAMA from Michael D'Angelica in the Memorial for Catherine that clearly showed that there is a reduced rate of infections putting antibiotics for. In our practice, in Whipple, when there are a stent or if it's an ampuloma, we always do bile duct cultures and we put those patients on 5 days on antibiotics. And after 2 or 3 days, we readapt them. So clearly we do that. That reduces the deep infections and also possibly the fistula rates. Because of the microbiota, I don't really know, but clearly that is in our practice first. Second, regarding you said the second question.
And I think it was about
drain,
minimally invasive. Yeah.
yeah. So drain in you also discussed drain in distal pancreatectomy. There is also recently published, like I think 2 or 3 weeks ago, the Pandorina studies, European multicentric randomized control trial, showing that clearly there is no benefit in draining those patients. On the opposite, it was also not huge deficit to drain it. So clearly, up to know you can drain it or not drain it, but if you don't want to drain it, it's fine. But if you drain it, I think the drain should be removed quite fast within a couple of days, especially if there is no pancreatic fistula. Also, if you discussed also the way to do it, laparoscopic or robotic. For distal, nowadays, with the diploma and the various Dutch trail, it has been proven that for a non-oncologic and oncologic procedure, distal pancreatectomy is fine. Clearly, it's not hugely superior. It's a little bit better for functional recovery, but it's not huge. So if you can do it, do it. But if you're not good at doing a distal pancreatectomy laparoscopically, don't do it and do it open as you used to do it. It's better to do a good open distal pancreatectomy than a bad laparoscopic one. So that is for distal. For Whipple, clearly it's very different. Laparoscopic one, I'm not fond of. I did about like 15s, but clearly. Here also the Dutch trial, which was the only one very well designed, showed there when you're doing laparoscopic Whipple, I mean, you have like poor results. So nowadays, except in very high volume centers, I think there is no benefit of that. We are waiting of the result for robotic Whipple, and there is ongoing trials. On my opinion, we show basically the same, that it is maybe as good as a laparoscopic one. So I'm not sure, but I think like robotic Whipples will be something that we're waiting for having, well designed randomized control study results.
Yeah, very good. One last question, if you can, please. So in your routine, daily practice, for example, after a complex Whipple, maybe with vascular resection or inflamed pancreas, what's your routine for before giving patient out the hospital? So do you use, for example, inflammatory markers? Do you do a CAT scan before to check if there is any liquid, or just fill the clinic evaluation, then liberates the patient?
Nowadays, I'm using the Porsche algorithm that had been also published in the Lancet by the Dutch group. And clearly, the Porsche algorithm is based on clinical evaluations, fever, health rate, on CRP, which I think very important, and in any doubt, CT scan. And those trials show that on a nationwide, just using a nice, cheap algorithms, you can reduce your mortality by 50%. And for that, you need to do more CT scans, more radiologic drainage, and more antibiotics. So basically, being more aggressive when you're dealing with those patients. So nowadays, I'm using a lot of CRP. If the CRP is slowly increasing, I will have a nice sleep and a good weekend. If my CRP is slightly increasing, I always do on Thursday a CT scan, on Friday a drain and antibiotics to have a nice weekend. So clearly, I'm on daily basis, I'm really using CT scan, CRP, and clinics evaluations.
Yeah, I agree. I think I would not be very calm to giving a patient to his home or her home with our CRP increasing, or even though if he's clinically well. So yes, very good. Thank you very much, Professor.
Thank you so much for your question. Very smart. Yes. Thank you.
Agatha, please. Up to you now, discussion.
Yeah, I have a few questions. We talk about distal pancreatectomy and duodenal pancreatectomy, but we didn't discuss the enucleation. Do you use another tools like hemostatic powder or another one in your choose? How do you?
No, when you're looking on enucleation, there is two stuff. There is the, like small exophytic, very nice lesions that are so easy to enucleate. And after you have the deep lesion within the pancreas. And for them, you have to clearly look at the distance between the main pancreatic duct and the lesion. If it's above 3 millimeter, it's fine. It's below, you should be careful of that, especially if in the head. So what you can do, you can either decide not to enucleate those patients and do a Whipple, or you can also use a stent insertions before the procedure. That might help you, to do like a tutorization of the duct, but with a risk of pancreatitis before. So there is no best practice for that, but I'm never using, any topic, power or Tacosil, because I'm using it sometimes, but, just as a mantra basically on a scientific point of view, it's not really decreasing any fistula rate.
Okay.
So it's more like enucleation, having the right indication more than the good topic on it.
Okay. And in an earlier slide, you said that you measure the amylases in the first post-operative day. In my hospital, in my practice, we do it in the third post-operative day. Do you think it's a change of practice? Or it impacts in the removal of the drainage? How do you think?
No, I think it's basically I'm doing on post-operative day 1, 3, and 5, basically.
Okay.
And that's helped me to, remove the drain earlier than before. If it's low on post-operative day 1, low on post-operative day 3, basically I take it out on post-operative day 4. If it's in between, I'm doing the post-operative day 5 because it's also the one that is defined, which is defining fistula. So you want to have it at least on academic purpose. So 1, 3, and 5, and after I see if I'm doing it. But as you say, I'm not sure that post-operative day 1 is much better than post-operative day 3. So you can either do 1, 3, or both.
Okay, thank you.
Welcome.
I'm not a panelist tonight, but I have some questions too. Sorry. I know
Welcome.
it's almost 1 a.m., but quick. I was very curious when you showed the slide about how many different surgical techniques we have available nowadays in literature. So at the end, you pointed that you should be between two, actually. Either you adduct to mucosa side end to side, or the one that I had the pleasure to see Jean-Christophe Vaillant perform in the past. I think that you know how he used to do. So I was very curious about how do you perform your Whipple procedures, and what is your option and why?
So for me, I'm not doing any more pancreatic gastrostomy because I'm not using nasogastric tube anymore. And clearly, doing a pancreatic gastrostomy without nasogastric tube is frightening. So only pancreatic jejunostomy. And when I'm doing pancreatic jejunostomy, I'm most of the time using a Bloom-Gart anastomosis. Why? Because it's easy to do and easy to teach, And when I want to do my younger fellow doing it, it's quite easy to do. Everybody can do it. So I think the Bloom-Gart one is a nice anastomosis, but he has clearly no superiority to other ones. I think you need to do one which is easy, which is teachable, and that you need to do every day. Otherwise, you shouldn't change your anastomotic techniques, but basically they are all the same, I guess. But for me, it's pancreatic jejunostomy with Bloom-Gart anastomosis.
Okay. And what else? You all said about the I didn't know that, at least when I was in France for my training back in time. I didn't know this technique of the double flap that you put
Yeah.
around the anastomosis. I did like it. So
Yeah.
do you use it every time?
Yeah, I'm using every time a mental flap. There is different way to do it. I was using the divided one previously. No, I'm using a retromesenteric one. I'm going behind the retromesenteric vessels, and that's covered nicely the superior mesenteric artery and all those arteries. I think that's important. That won't prevent the pancreatic fistula occurrence, but when it occurs, that will decrease its gravity, protecting, your vessel and the gastroduodenal stump. So clearly, I'm doing all the time, except if there is a very thin omental, but I'm doing all the time an omental flap. It takes you 5 minutes more, but it's very efficient.
One last question. You said that you had an experience in laparoscopic surgery of around 15, 16 cases.
Yeah.
And when you did it, did you perform your pancreatic jejunostomy in the same way that you perform in open surgery? Or did you change
No,
anything?
when I was doing them, I was doing an hybrid technique. I was performing the resection laparoscopically, and I was doing a small opening for the anastomosis.
And then you did the Bloom-Gart
Bloom-Gart anastomosis as that. And I was doing a small midline incisions, but I was not convinced. I wanted to do it, just to, make my own opinions. But clearly, the 15 I did went fine because there was selected patient. I was very careful, but I didn't observe any true benefits, and the issue with pancreatic surgery in opposition to colonic surgery, I mean, the morbidity is not in relation with the abdominal wall opening, the morbidity is in relation with the pancreatic fistula. And doing it laparoscopically or manually, that will carry, I guess, the same risk of pancreatic fistula. And clearly, I think that doing it laparoscopically, you need a huge exposure and a huge skill. Maybe a robot might help because doing, like the anastomosis robotically will clearly, I think, help to do it better and probably much better than open. We'll see.
Okay, yeah. Felipe or Aga, yeah, Felipe, please.
Just to add, we also like to use the round ligament sometimes. So you prepare it in the beginning of the surgery just to have it a length enough. And we used to do the hybrid in the beginning of our laparoscopic invasive experience. The impression we had was that the patient had less pain, maybe, but the rest was very similar. Now we're doing a lot of robotics, so we changed it. We moved to robotics, so it's easier to reconstruct it, and I think the resection may go very well too.
No, yeah, clearly the reconstruction part will be much easier. For the pain, clearly, we are using peridural for all our patients, and when you use it open or, laparoscopically, basically, they're like on, sit on the first postoperative leader. So I think it's not the issue, but the hybrid technique, on my opinion, even if I was doing it, is, a nonsense. You have like the detrimental of laparoscopic and the detrimental of open, But the robotic one, we don't have a robot yet in those institutions, or we're sharing with too many people to start our pancreatic robotic program. We will have one very soon, but I will be very interested in performing laparoscopic Whipple, so robotic Whipples. We'll see what will be the result of the following trials.
I got one more question.
No.
Oh, so I don't have either. So I just would like to thank very much indeed to the panelists, as well to Professor Gaujoux, which is this is the third time that he teaches us his experience at this time of the night. It's nearly 1 a.m. in France, and every time it's an outstanding presentation. So thank you again. I know it's a huge sacrifice that you don't hesitate to accept our invitation every year in a row. Thank you. I do appreciate and I do value all your efforts to be with us at those time of the evening. Thank you.
No, it's my pleasure. Thank you very much. Hope to see you once in Brazil or in Paris, and have a nice evening in Brazil.
Thank you. Thank you again.
Yeah, you too. You too. Thank you. Thank you.
Bye,
Bye-bye.
guys. Thank you.
Bye. Have a good night.